I will be speaking about the various trials and the newer treatment options available as a targeted therapy in stage 4 NSCLC. After this talk by Dr. Arpana, so we have spoken about what are the different kind of molecular targets that are available and what are the newer targets. So we will be quickly running through all the different kind of targeted therapies available and what are the different kind of targets that we have been discussing. So these are the established biomarkers, EGFR, ALK, ROS, BRAF, which we have been discussing for quite some time now. And there are a few other newly available biomarkers, which are NTRK1, MET exon 14 mutation, RET fusions, and HER2 amplifications and mutations also. So what newer drugs are being used in these newly available biomarkers, we will be discussing about that. So this is not a one disease, this is a collection of many different kind of disease. Adenocarcinoma and squamous cell carcinoma, they were just two diseases earlier when the only histology was available, but now the adenocarcinoma and squamous cell carcinoma is basically the collection of various heterogeneous diseases in which the oncogene addiction is there. These are different kind of oncogenes which we have been discussing. So, whenever you have a diagnosis of CA lung, biopsy to establish diagnosis, and then biomarker testing. So at least testing for EGFR, ALK, ROS, we have been doing this for quite some time. Now we have extended doing testing for BRAF, NTRK1, RET, MET, exon 14 in all non-squamous NSCLC. So we're also doing a upfront evaluation of PD-L1 for all those patients who don't have these targeted biomarker testing positive results. So as of now, these are the various markers for which different kind of drugs are available for EGFR, ALK, ROS, BRAF, and NTRK positive mutations, and entrectinib and larotrectinib. April 2021, the first line option for MET exon 14, RET, and newer option for ALK and ROS, they became available. So we will be discussing a few of the case scenarios, and then we will be discussing the data about it. So this is a 56-year-old non-smoker gentleman. The CT scan showing large left upper lobe mass with extensive metastatic lymphadenopathy with cervical lymph node biopsy revealing stage 4 adenocarcinoma and brain MRI showing 3 small lesions in frontal lobe, which are not symptomatic at the moment. So NGS biomarker showed EGFR deletion 19 mutation positive and negative for all other mutations, PD-L1 being 60%. So this is the phase 3 FLORA trial, and OS, it has definitely improved with osimertinib and advanced EGFR mutation in NSCLC, and this is the standard of care nowadays for stage 4 EGFR mutated lung cancer. You can see here that CNS progression is also quite low. CNS PFS is definitely statistically significant in those patients who received osimertinib. This is another case, similar patient, 56-year-old gentleman having ALK rearrangement. All other mutations, they are negative, and PD-L1 expression is 60%. So option here are crizotinib, the much initial option, which we used, then ceritinib approved in 2017, alectinib 2017, brigatinib, and now we have a front option of using lorlatinib or in sequence. So expanded approval for frontline setting in lorlatinib has been given in March 2021. So this is lorlatinib, which has got broad activity against ALK resistant mutation. So the point is that if we use lorlatinib upfront in this setting, then the secondary ALK mutations, they tend to be low on disease progression, and hence it has got maximum PFS amongst all the ALK TKI at the moment. So secondary mutations in ALK kinase domain can induce resistance to first and second generation ALK TKI. These are all the mutations in which the crizotinib is active. So sequencing is one of the option, and using upfront lorlatinib is another option, which came from phase 3 CROWN trial, and it has shown superior PFS as compared to the standard of care crizotinib. But it comes with a unique toxicity, and lorlatinib is associated with hypercholesterolemia, hypertriglyceridemia, edema, increased weight, peripheral neuropathy, and cognitive effects. This is another case, similar 56-year-old gentleman having ROS1 rearrangement positive on next generation sequencing and PD-L1 expression being 60%. So this was the crizotinib first agent which was approved in ROS1 positive NSCLC from profile 1001, and this is the OS in ROS1 positive patients. Median OS achieved here by crizotinib was 51.4 months, and overall responses can be seen in this nice waterfall plot, which is close to 72%. Another drug, entrectinib, which has shown its efficacy in ROS1 positive NSCLC. Especially the good thing about entrectinib is the good amount of brain penetration which it achieves as compared to the crizotinib. And median PFS in all the patients we can see here is 15.7 a month, and those patients who had CNS disease, even in these patients, the median PFS was 11.8 months with this new molecular entrectinib in ROS1 positive NSCLC. So these are other few molecules which are active in ROS1 positive NSCLC. Lorlatinib is one of them, which can be used sequentially. You can see that intracranial overall response rates, they are highest with entrectinib. Median PFS is highest with lorlatinib in crizotinib naive patient. But efficacy in pre-treated patient is also present both in entrectinib and lorlatinib. Although at the present moment, the lorlatinib, the company is not giving patient assistance program if you're using lorlatinib in first line setting or second line setting after progression on crizotinib in ROS1 positive NSCLC. So these are different kind of side effects which come with these kind of drug which we use. Crizotinib, entrectinib, lorlatinib. I think the best one would be entrectinib. We are seeing the overall intracranial responses. Repotrectinib is still not available. So this is another case, and this patient had BRAF V600E mutation positive NSCLC, PD-L1 expression being 60% here. This is the frontline usage of dabrafenib and trametinib combination in BRAF V600E positive NSCLC. Total of 36 patients they were analyzed, and you can see here that overall response rates for dabrafenib plus trametinib combination was close to 63%, and a few odd patients they will achieve complete responses, but most of the patients they have a partial response on this treatment. So this also comes with few other kind of toxicity, and most important toxicity with this is abnormal kind of fever that patient can have, and few of the patients they can have very bad skin rash on being on this treatment. So these are the new therapeutic targets in NSCLC beyond EGFR, ALK, ROS, and BRAF. We will be discussing about NTRK, MET exon 14 skipping mutations, and red gene fusions. The similar patient with NTRK fusion positive NSCLC, all other mutations being negative, and PD-L1 expression is 60%. The brain MRI is still showing 3 small lesions in the frontal lobe. So NTRK rearrangements and TRK fusions in cancer, they are especially seen in those cancers which are rare. So commonly seen in those cancers which are rare, such as brain cancer, glioma, GPM, salivary gland tumors, very few lung cancer patients, secretory breast cancer patients. So here, and they are also seen in the thyroid cancers in children, the infantile fibrosarcoma, then congenital nephroma. So the NTRK rearrangements and TRK fusions, basically the normal role is in the neuronal development. It helps in the postnatal neuronal differentiation, survival, and function. But when the rearrangements in this gene is present, it leads to the overexpression and continuous activation of tyrosine kinase domain, leading to different kind of cancer. And these cancers, they are addictive to this gene. So larotrectinib is the drug here, which is treatment of choice at the moment. And the overall responses, you can very clearly see here in this waterfall plot, are to the tune of 79%. Median duration of response with entrectinib is 10 months. And if you talk about larotrectinib, the median duration of response is 35 months. So entrectinib has overall responses to the tune of 57%, larotrectinib 79%, median duration of response almost 3 times in larotrectinib as compared to the entrectinib in these patients. So this trial involved all different kind of patients. It was a basket trial in which sarcomas, thyroid, NSCLC, CRSF, they were all included. So if you see the intracranial overall response rate with pan-TRK inhibition, so the intracranial responses are to the tune of 54% in entrectinib. You can see on the right hand side the efficacy of this drug in the intracranial as well as the lung lesions, which we can see after 3 cycles of larotrectinib. Few of the side effects with this drug, they are peripheral edema, paresthesias, arthralgias, myalgias, weight gain, and muscular weakness. So NTRKs, they are very rare. Larotrectinib and entrectinib both show significant clinical activity. On November 26, 2018, larotrectinib was approved for NTRK gene fusions. This is another case, similar patient, 56-year-old, brain lesion 3 and MET exon 14 mutation, they were positive by NGS, PD-L1 expression being 60%. So this MET has normal role in embryogenesis and wound healing, and skipping mutation in exon 14 causes inflamed deletion of juxtamembrane domain, leading to increased stability and constitutive kinase activation. This is profile 1001, crizotinib, initially used in MET exon 14 altered NSCLC. And the response rate, overall response rates were 32% with this drug. But there are few other drugs which have potent efficacy against MET exon 14 skipping mutation. So crizotinib is one of them, cabozantinib, savolitinib, tepotinib, and capmatinib. So if you see the IC50 concentration on which the drug acts, it is minimum for capmatinib, and we have the trial with capmatinib, then tepotinib. Savolitinib, cabozantinib, and crizotinib, it is highest IC50 concentration. So even at very less amount, the capmatinib would inhibit MET14 altered NSCLCs. So recently approved selective MET inhibitors are tepotinib and capmatinib. Capmatinib is highly selective MET inhibitor. Similarly, is the tepotinib. So this was the geometry mono 1 trial for capmatinib in MET exon 14 mutation positive NSCLC. The patients, they were treatment naive or pre-treated, and they were received 400 milligram of twice daily capmatinib under fasting condition. These are the waterfall plot with this capmatinib in mutation positive NSCLC. These were the no previous treatment patient, and these were the previously treated patients. So 68% patient responded, and here 41% patient responded. Those patients who did not have previous treatment, the 68% patient would respond. So first line duration of response was 12.6 months. Second line duration of response was 9.7 months. Progression-free survival 12.4 months, and second line 5.4 months with capmatinib. This is another trial, Vision, tepotinib in MET exon 14 mutation. MET exon 14 skipping mutation was detected by tissue or liquid biopsy, and these patients received tepotinib 500 milligram every 21 days. So these are the waterfall plot with phase 2 Vision trial in tepotinib, and the overall response rates, they were quite high. So there were 2 cohorts. One cohort in which the biopsy was liquid biopsy, and another cohort was the tissue biopsy. So if you see the liquid biopsy and if you see the tissue biopsy, those patients who had tissue biopsy positive MET exon 14 mutation, they had better duration of response and better progression-free survival as compared to the liquid biopsy. So MET inhibitor, the side effect, peripheral edema, which is common, and then increased creatinine in few of the patients, but not grade 3 or 4 creatinine clearance increase. This is the summary. Crizotinib has high activity but poor CNS penetration. Next generation MET inhibitors are capmatinib and tepotinib, which are also active with improved penetration in CNS. This is another patient who had RET fusion positive NSCLC, similar 56-year-old gentleman, non-smoker, with KIF5B RET fusion positive NSCLC, PDL1 being 60%. So the RET multikinase inhibition, these are the drugs which inhibit RET: cabozantinib, vendatinib, selpercatinib, and prasitinib. But you see the highest IC50 concentration is with cabozantinib and least with prasitinib and selpercatinib. And overall responses, they are highest with these two drugs, LOXO-292 and VLU-667, to the tune of 68% and 58%. Cabozantinib and vendatinib also inhibit RET, but they have plenty of off-target effect as well. So the drug of choice, they are selpercatinib and prasitinib at the moment. So these are the two drugs which are approved for this RET inhibition. These are the Libretto trial with selpercatinib, and this is the phase 2 ARROW trial with pralsetinib for breast fusion positive NSCLC. And in both of these trials, the PFS was to the tune of 16.5 months in selpercatinib trial and 11.3 months in pralsetinib trial. So all these newer generation RET inhibitors, they are active in brain. This is very, very important. And overall response rate, we can see are to the tune of 91% for selpercatinib and 56% for prasitinib in these clinical trials. So May 2020, the FDA approved selpercatinib for the treatment of RET fusion positive NSCLC, and prasitinib was then FDA approved in September 4, 2020. So this is the current treatment paradigm for molecular biomarker positive advanced NSCLC. This was our first slide. And 35% of the patients with advanced NSCLC having driver mutation by FDA approved agent. So this is how it goes today. So what about those patients who receive first-line checkpoint inhibitors in metastatic NSCLC with high PDL1 expression and driver mutation? So all our previously discussed patients, they had PDL1 expression of 60% with some kind of additive driver mutation for them. So this is some trial data which we can see here that there is lack of efficacy with immune checkpoint inhibition in EGFR mutation positive NSCLC. So phase 2 study for pembrolizumab with PDL1 expression positive EGFR mutation positive NSCLC, it was stopped for futility because it did not work in these addictive patients. There is potential toxicity also with sequential use of immunotherapy followed by oral TKI. So if you use immunotherapy followed by osimertinib within 3 months of immune checkpoint inhibitor, 24% of the patients will have some kind of severe immune response phenomena, and very many patients, they can have grade 3 pneumonitis or grade 3 colitis and grade 4 hepatitis on sequentially using immune checkpoint blockade followed by osimertinib or osimertinib followed by immune checkpoint blockade. So talking about HER2 positive patients, HER2 overexpression can be seen, HER2 amplifications and HER2 mutation, and these are the targetable biomarkers which we have at the moment. So this is positinib. This is second-line therapy in advanced HER2 exon 20 insertion positive NSCLC. It's phase 2 Zenith 20 trial with positinib in advanced EGFR HER2 exon 20 mutation positive patient. It showed a significant advantage. So positinib for HER2 exon 20 insertion positive NSCLCs. Trastuzumab emtansine TDM1 in mutated HER2 mutated lung cancer. You can see here that overall responses are to the tune of 44%, and PFS is to the tune of 5 months with TDM1. This is another Destiny Lung 1 trial for trastuzumab deruxtecan for those patients given in the two cohorts, one HER2 overexpressing and other HER2 mutated. And you can see here that primary endpoint were overall response and secondary endpoints were PFS and overall survival. If you see here, Overall responses were to the tune of 61%. The disease control rate was to the tune of 90%, and median PFS was around 14 months in this Destiny Lung clinical trial. For the mutated patients, for overexpression patient, the PFS was 5.4% and median OS was 11.3%. So HER2 mutated patients, they respond better to trastuzumab deruxtecan. But TDM1 and TDXT, it comes with toxicity also. The most important toxicity in which we are afraid of is interstitial lung disease, and few of the patients, they can have very immune suppression and leading to decreased TLC and febrile neutropenia and deaths also. So these are the toxicities. Those in dark blue, they are grade 3 toxicity. So febrile neutropenia, grade 3 neutropenia, they are very common. We have to be very cautious about it once we are using this treatment. Targeting HER2 in NSCLC, so we have already discussed. KRAS, this is the last topic which I'm going to discuss, and KRAS mutations, they are common. It has been very, very challenging till now targeting KRAS mutations, but now we have a drug, sotorasib, 4-break trial, and these are the patients who had locally advanced or metastatic NSCLC, and they had progressive disease on previous standard treatment. So they were given sotorasib 960 milligram. If you see here, the median age was 63, and most of the patients, they were smoker. So 90% of the patients, they had smoker, and almost all the patients, they had received immunotherapy also and chemotherapy also. So 90% patients, they had received PD-L1 checkpoint inhibitor before getting this drug in the clinical trial. You see the overall response rates, they were to the tune of 37%, and disease control rate was to the tune of 80.6%. This is the depth of response. And the durability of response, the median duration of response was to the tune of 10 months, and disease control rate was 80.6%. So till now, the targeting KRAS was extremely difficult, and now we have a drug for this also. So with this, I think I have covered many of the mutations in lung cancer, which we have not been doing for last so many years. With this, I would stop, and the topic is open for discussion.
Hi, Manish. So it was a wonderful, elaborative session taken by you. And you have covered almost all the molecular aberrations and their targeted therapy. I would like to ask one question, Manish. The same question you asked Dr. Aparna also. So what is your clinical practice if your patient is having all the finances? So do you really proceed with liquid based plus biopsy based, both the NGS, or you prefer one of the two?
So I have been doing tissue NGS at the moment. It becomes extremely problematic for patient and doctor to send both of the sample and then track both of them. But I think it makes sense if you have all the finances. You can see the tumor heterogeneity. You can definitely look at the mechanism of resistance a patient tumor can have. I think it makes some sense. Are you doing that?
No, the practice, my practice is I always prefer FFP, and if tissue is not there, then I try to do it on the liquid biopsy. And have you ever done NGS, liquid biopsy based NGS on any other tissue, like apart from blood, like in CSF or urine or pleural fluid? Have you ever tried that?
No.
So is Dr. Aparna here?
I'm here.
Yeah, hi, Dr. Aparna. Again, I'm asking the question only.
No worries.
So in RGCI, we used to do EGFR mutation testing on other samples also, like CSF we have performed, then pleural fluid we have done, then ascitic fluid also we have done. But I'm not sure of the validation for that, and I'm not sure of whether other tissues, other fluids can be used for NGS-based platforms or not.
So they can be used. So I know when we talk about liquid biopsy and all these conferences, we go on talking about NGS blood, but actually liquid biopsy can also be done on CSF. It can be done on, a plethora of different sample types. And I know in RGCI, Dr. Moshmi and team have done a fantastic job in validating it on CSF. So from the technicality perspective, I don't see it as a problem as long as it's validated. I think it's got a good sensitivity. I know a couple of my patients have actually come to RGCI and had it done where, have had themselves tested at with Dr. Moshmi. So I think I don't see a problem with it. As long as the validations are in place, there has been concordance or some sort of a thing established and liquid, irrespective of the liquid sample type, I think it's a good alternative, especially in this early, early lung cancers, where where the ctDNA count may be low. I think we can use it.
Okay. Thank you. And is the amount of sample also a challenge, like in CSF? So we might get only 0.5 or 1 ml or 2 ml as a sample. So is it adequate usually for doing or to extract the DNA out of it?
So logically, yes, but then again, it depends from lab to lab as to what is their protocol for DNA extraction. Every lab is different. So while your lab may say, RGCI may say 2 mils is enough, my lab may say 1 mil is enough.
Okay.
So it varies from lab to lab and how it's been, and how it's been validated.
Okay. Thank you, Dr. Aparna.
So, Dr. Praveen, we had a patient of CA lung who presented in very bad shape in ICU and with meningeal disease actually. So we were not able to perform a solid biopsy for that patient, and somehow because of the meningism, we did a CSF study on that patient, and then we did a NGS, and unfortunately that NGS came out to be positive. We started that patient on osimertinib. But I think we lost that patient, did not work well for that patient. So I think there are few of the clinical reports that say that we can do these kind of testing in other fluids as well. I think Dr. Lars has been doing this in pleural fusion also, I think, no?
Yeah. So we have seen in all sort of samples. In CSF also we got, in fact, if you speak about the CSF, then you tend to see the heterogeneity in the resistance mechanism also. Like many a times what you have seen is that your T790M presence after treatment, it happens only in the extracranial site on many occasions, and intracranially it is still sensitive to your first or second generation TKI. They do not have T790M. I think Dr. Aparna, you can elaborate on the same thing if you have any experience regarding the same.
No, that's very true. We have seen CSF as and again, I've had it tested at RGCI. We've not done it in any of the labs that I've been associated with, but it does a fantastic job. It does exactly what liquid biopsy is supposed to do, irrespective of the sample, blood or CSF or pleural fusion, and it helps call out those clonal. It helps call out tumor heterogeneity. We're able to track those resistance mutations. So all those options are there, and I think it's a brilliant sample type to use. The only thing is CSF sometimes is a little invasive and can be a little difficult extracting that. So blood would be an easier alternative, but if blood's an issue, CSF, I think, excellent results, and especially in calling out the C790M and the C797S. It's really, really good. It boils down to the lab. I think at the end of the day, it's the lab, their practice, their validation, their protocols. If your lab is good and it has the right technical team, then doing all this stuff is, I'm not going to say it's child's play, but they definitely have the elegance in performing this testing, which obviously benefits us, our patients in a clinical setup.
Okay. And so, Dr. Aparna, one more practical question. So, see, I have shifted from RGCI to Akash Healthcare, and we have that challenge that we do not have any molecular lab with us. So, like if we are doing a CSF analysis or if we are doing a pleural fluid analysis and we want to perform some molecular liquid-based assays on that, so is there any specific technique we have to follow, like for cell block, sometimes you need to take the fluid in the formalin only, and then you have to send the fluid immediately. Because if you are taking it in formalin, I think the fixation happens over there only. But if you are not taking the fluid in the formalin, then issues are there. So can you just if
Sure. So it depends on the tube in which you collect the sample. So we have like how when we take a blood sample, we put an EDTA, those purple top tubes. It helps preserve the DNA when we're doing germline testing. The other option that we have when we're doing ctDNA, we use Streck tubes. These Streck tubes have a solution which helps in enumerating and preserving the ctDNA. So it's either from PaxGene or it just increases the stability of the sample. So by the time you take the sample in your lab, in your hospital, and you call your service provider, whichever lab it is, it helps maintain the stability. And as long as you keep it in minus 80 degrees, I don't see it as a problem. So it's kept at minus 80. During transportation, you maintain those temperatures, not minus 80, at least a minus 4. Maintain those temperatures and have it delivered to the lab. We've not seen issues. We get samples from pan-India, international. As long as temperature is maintained, shouldn't be an issue, especially if you don't have a molecular setup in your organization.
So, Dr. Aparna, do you do only EGFR on these kind of sample, or whole of the multi-gene multiplexing can be done on these?
We're doing multi-gene, but then again, I am not doing it on CSF. I think in India today, only RGCI has that ability, has the capability and the ability for it. But we do it for multi-gene. So you have it as standalone, just EGFR. Then you can do just a very typical lung cancer panel. Then you can go beyond the lung cancer 12 gene and look at far many more genes. So we're doing it all now.
So I think, Dr. Praveen, we are getting late for the next session. Dr. Babu is here. Thank you, Dr. Aparna. Thank you, Dr. Praveen, for this wonderful and nice discussion. So I would